No? Cool. All right. Orthopedic injuries. What are we talking about when we talk about orthopedics? Bones connecting.
Sorry, Professor A.
Yes.
I couldn't get unmuted fast enough. I'm sorry. I'm going to be up there in a few moments. Are our badges working so I can get in the building, or are they still having props?
No, you'll still need to come through the back, and then just, or actually, if you go up front and let Christy know that you need Clary, she can walk you back.
Okay.
Okay. Yeah, guys, bones, ligaments, tendons, all of the surrounding tissues that help keep the bones intact and connected. Joints, all that fun stuff. All right. So guys, real quick recap. What do we have bones for? Why do we have bones? Okay, upright structure, posture, what else? Movement. All right, what else? Protection, right? Rib cage protects heart, lung, great vessels. Okay, the skull protects your brain, all that fun stuff. What else? Okay, so helps with the production of red blood cells. 3 types of muscles in our body. Smooth, skeletal, cardiac. Where do we find cardiac? In the heart. Where do we find smooth? All right, so organs, they are what? Involuntary, we can't control them. All right, skeletal, or they are voluntary, but what are they also called? Huh? Striated. Okay. So yeah, we find those in the involuntary, voluntary, and involuntary, but still just in the heart. All right, guys, our bones are surrounded by ligaments. They're surrounded by muscular content, right? We have vascular components to the muscle, to the bone, ligaments, tendons, all that stuff. Nerves, that's a big one too. That's why it hurts. So this is more so. No, I know that. Go over your major groupings, right? We've got the shoulder girdle. We've got our joints there. We've got the thoracic component, the rib cage, our pelvic girdle. Remember all of the upper extremity bones, the lower extremity bones. Did I go with that? Now we're going way back in the vault for those things. Okay. We just talked about the skull for head and face. As we have our shoulder joint, what helps compose our shoulder joint? Okay, so clavicle, scapula, the acromion process. We've got the humeral head that helps form that joint. Okay, what kind of joint is the shoulder? Ball and socket, right? We can do in a circular motion. We can go up, we can go down, forward, backward, all that jazz. So when we talk about injuries to the joint itself, what are some things that I'm concerned with? Okay, so dislocation, meaning what? Okay, so that humeral head can kind of pop out of that socket there. It's not where it's supposed to be. It's not sturdy. It's not stable. And we can see some movement issues. All right, what else can happen? Okay, so maybe a sprain, the surrounding ligaments or tendons or muscles can become affected, maybe overstretched and compromise the strength of that joint. What else can happen? Fractures of what? Any of the bones that go into forming that joint, right? So what else can happen? Another big thing that can happen, particularly in the shoulder and the hip. Tears, maybe. Remember, guys, we can have a fracture right here where like the humeral head or the femoral head is actually significantly impacted. Okay, the fracture could occur right below the head of that bone. So the bone's not, the shaft of the bone more so is not connected, but the head of the bone is still intact. So there's a lot of different things that can go awry at joints. Just remember what helps create joints, what helps form them. Everything that goes into it can be impacted in some way, shape, or form. Do we need to go over bones? Okay, no. Everybody good with bones, lower extremity?
No.
No?
No.
Thank you for speaking up. So do we want to go over just the leg or should we do? Huh?
No.
Oh, okay. Feet?
No.
Hum, hum, hum. All right, fractures. What's happening to have any kind of fracture? Okay. All right, so the structure of the bone is compromised for one reason or another. There's somewhere in the any aspect of the anatomy of the bone, we have a break in the continuity of the bone, whether that's in like the head aspect of the bone or right in the shaft, if it's a hairline fracture, if it's in any way, shape, or form, the continuity of that length of the bone is compromised, we have some type of fracture. All right, look, closed or open. What do you think is going on with a closed fracture? And it's not broken. All right, we can still have signs and symptoms that can lead us to believe, hey, you probably have a broken bone, but we don't have anything obvious like a broken bone sticking out of the skin. All right, so that's going to be an open fracture when the skin is compromised, when we can visibly see where, well, maybe not where, but the physical evidence of that break in that bone. Okay. All right, so here's some visual representations of different types of fractures. Okay, so comminuted, we don't have one of these here. That's going to be where the bone is broken up into more than two certain sections. Okay, so if we have multiple breaks in the same bone, then that's going to fall under that category. Epiphyseal, what is this?
Fracture in the growth section.
There we go. Fracture in the growth section. All right, so if you fracture like your growth plate in a particularly like a long bone or a joint or anything of that nature, what's our biggest concern there? Okay, it could possibly compromise the growth. We're really concerned about these types of epiphyseal fractures in who? Kids. As their bones are still getting longer, they're still getting stronger, they're fully maturing. If we have a significant injury to the epiphyseal aspect of that particular bone, it is quite possible that that particular bone will not grow any longer or grow any bigger. So we can understand how that can cause some problems later on down the road. Green stick, incomplete fracture that passes only part way through the shaft of the bone. We see these a lot in who? Okay, so maybe athletes, particularly that have kind of like a twisting motion sometimes. Who else? Okay, geriatrics, typically pediatrics. Okay, guys, what is true about pediatric bone composition? So they're very spongy, they're very pliable, they're flexible, if you will. Okay, because they are still growing in length, because they are still growing in strength. Now, guys, you can't take a bone and just like, you know, like a silicone straw, bend it and you know, manipulate the shape. But they are prone to having incomplete fractures, like partial fractures, because they don't have that firm density like adults do. So whereas an adult, if we had, you know, a fall down the stairs or whatever it might be, our bone might totally break in half because it's very rigid, it's very firm. Whereas the kids' bones, they're a lot more pliable, so it might actually bend under pressure a little bit and only have a partial fracture. So keep that in mind about children's bones. They're more bendable to a certain extent, but we start to see these incomplete fractures more so than just straight up broken in half, if you will. So kind of in the same sense, an incomplete fracture, it doesn't go all the way through the shaft of the bone. It just kind of goes, starting to go towards the center point of the bone, but it doesn't go all the way through. Oblique, broken at an angle. Pathologic, this is a fracture due to what?
Previous fracture.
Not such a previous fracture.
Kind of medical reason.
Yeah, brittle bone disease, osteoporosis. All right, so if we have a patient who has that condition, they're going to be a lot more susceptible to a broken bone, and it would, depending on the way that you looked at it, depending on what doctor, they would say, oh, you didn't break your bone because you fell, it was just because your bones were weak and couldn't handle the fall type thing. Exactly. Spiral fracture, okay, fracture caused by twisting force. Typically this is oblique, it does not go all the way through the shaft of the bone. Where do we see this a lot? So maybe athletes, who else? Children, right? Particularly what with children? A lot of times we see this in sometimes abuse, right? If they're trying to like snatch up a kid and the kid's like trying to get away, he does like that twisting motion. Sometimes it's unintentional, like if the kid's about to run out in the middle of traffic and mom goes to grab him and the kid kind of has that twisting motion. We see this a lot with pediatrics, especially because of the pliability of their bones. It's not a complete through and through fracture, but that twisting mechanism creates that partial fracture. Transverse, straight across the bone. Just typically like a through and through, if you will. It's just going to be a nice, not clean, but just a line that goes across the entire diameter of the bone. Okay. So guys, we need to know the definitions of those, right? But do we so much care about, oh, this is an oblique fracture or this is, this fracture? Okay, are we going to be able to tell that all the time?
No.
Right? Because guys, a lot of these, especially if you look through with here and even here, it's going to hurt unless there's like a bone definitively sticking out of my patient's skin, or I see something very obvious like that. It's very possible that it could be what? What all could be going on? Okay, it's going to be painful, right? It could be any of the fractures, but it could also be what? If I don't have that x-ray vision and take an x-ray on scene and say, yep, you definitely have a fracture. It could be a sprain. It could be overextension of maybe a tendon or a ligament, or the muscles were overexerted. Okay, so how do you think we're going to go about saying, ooh, yeah, I really think this bone is fractured? What are some things that we can say? Okay, so we can palpate for tenderness. Anybody ever sprain their ankle or strained anything or pulled a muscle? Did that hurt when you touched it? Yeah. Anybody ever broken a bone? Did that hurt when you touched it? Okay. Can be. Maybe not for some people. Pain's perceptive, or pain is subjective, right? What else can we do? Okay, so we can compare it, guys. That's another big important thing, especially talking about orthopedic injury. All right, because if you were to come, if I called 911, you had no idea why you were here for me. If you did a head-to-toe assessment, you would probably think that I called you because of a knee injury. Because of all my surgeries and all the issues I've had with this knee, it's not the same shape as this one. It's really weird. This is like a lot more round. It's not very defined. This one looks like it's swollen all the time in comparison to this one. So when we talk about these orthopedic injuries, one big part of our assessment is to compare that affected area to its counterpart, right? So I would say if we had a call for somebody who rolled their ankle on the sidewalk, okay, I'm going to look at, let's say it's the right ankle. I'm going to look at the status of that right ankle, how swollen it is, the normal like kind of shape and appearance of it, and compare it to the left one. Okay, because what are some possibilities that could be present within my patient that could give us a baseline presentation that we might think is an injury, but it's not really. Maybe fluid retention,
Pedal edema if they have CHF.
maybe pedal edema. What about like arthritis? That affects what?
Joint size.
The joints. And actually the size of them, the shape of them, the direction. My mama had it so bad, all of her fingers were like completely twisted sideways. All right, so if somebody had come up to her and didn't know what was going on and looked at her hand, they would thought that, you know, the Russian mafia came and like broke all of her fingers individually, right? But both of her hands were like that. She had baseline rheumatoid arthritis. What else? Anybody know anyone that has gout? That can cause significant swelling to the joints as well. So we want to ask our patient what? We're going to compare it to the other side. All right, but we want our patient, if they're coherent, if they're conscious, we want to ask them what?
It was normal for you.
Does it always look like this? Is the presentation of this joint or this extremity or this area of your body, is this normal? Right? Because what if I come up to somebody who's got a swollen right ankle and be like, oh yeah, no, that's pretty standard, my gout's flaring up. Am I really concerned that they broke their ankle? Probably not. So just make sure that we're comparing one side to the other. And we're going to ask our patient if this is baseline, if they have anything else going on that makes it look different than the other side, or if this is something totally unrelated to a traumatic injury. Is that fair? Yeah, that's definitely a fracture, right? Does it always look like that? Guys, what do we call this?
What do we call that?
Just globally, what do we call that? That's a deformity. Guys, if you look at somebody's bone and say, dude, that is jacked up, that's a deformity. Okay. You could maybe consider this, like right here, an angulation. But that's typically when something's going at another angle that it shouldn't be going. But yeah, this is just going to be globally, that's a deformity. That does not look like it should. Now, if my patient had like rickets or like had bow legs, maybe that could be baseline for my patient, but I'm going to go ahead and say something's broken there. What else can we do to assess and say, yep, we got a fracture? Maybe discoloration, strains, and sprains. As I sprained the crap out of my ankle in high school, and it was black and blue and purple for weeks. So we can have bruising with strains and sprains just as well as broken bones. Yeah, I'm missing the very obvious one. Crepitus. Right, guys, that's why we assess the upper and lower extremities. We're assessing to see if that bone is in that continuating line. That's why we do that staggered hand pressure test. We're pushing the bone into itself to see if the structure is intact, and if it is, it's not going to go anywhere. Right? But if we've got any type of fracture, especially if it's a significant fracture, we're going to feel that slack when we push it up against each other. So if we have obvious crepitus or that instability, yeah, something's broken. We might not be able to tell you what kind of fracture, right? If it's not like an open skin fracture, but if I have instability or crepitus, that structure is not sound. That's going to be a fractured bone, right? You feel crunchy crunch, something's broken. Okay. So yeah, that's fairly accurate to how my knees look. You can't really you can't see like a definitive kneecap in my right knee, whereas you can in my left. It's probably because I have like no meniscus left, and I have arthritis, all of that stuff. But yeah, my knees don't look unison. Locked joint, what does that mean? Okay, so that means that I can't, if I had some type of trauma and I'm suspecting I've got a fracture or something that's affecting my joints, I'm not going to be able to fully extend my arm or flex it, right? I'm not going to be able to freely move that joint like it's supposed to be. Another very common etiology of locked joints is torn meniscus. Every single time I tore my meniscus, it was like somebody put a door jamb in my knee joint, and it didn't necessarily like physically hurt to do it, but I could not move my knee past a certain point. It was like somebody put a door stop in there. So we can infer there could be all sorts of things, maybe connective cartilage, that meniscus, the bone itself, the joint itself, but if they aren't physically able to move a joint in any capacity, something is going on.
Could be neuro too.
Could be neuro. All right, so everyone's clear on what the medical term for a joint is, right? When two bones come together, we have to have those connecting tendons and ligaments and all of those surrounding structures to help it move cohesively. Okay, so dislocation is when these bones are no longer have that connection. Whether it be that it's popped out of the socket, whether it be that there's some type of fracture to one of those involved bones, we're not able to have that kind of contact in between that area to have that free movement. Sometimes a dislocated joint will spontaneously reduce. What does this mean? All right, has anybody ever popped something in a socket? What happened?
Kneecap.
Okay, did it pop back in? No. Okay. You have?
Yeah, I just repaired the shoulder.
Did it go back in?
Yeah.
So sometimes, guys, it's the craziest thing because what helps hold these joints together? Tendons, ligaments, muscles, right? So sometimes commonly you see this with either kneecaps or shoulders. If they pop out of place, what's happening to those surrounding structures? There's what? There's tension, right? So if that patient maybe moves their arm, because guys, they're not really going to be able to freely move. When you pop your shoulder out, could you really move your arm or any aspect of it? Yeah. Sometimes the tension on those surrounding tissues, those muscles and those tendons and those ligaments, the tension is so strong that it'll just kind of pull it back to where it needs to be. That's what we call spontaneously reduce, if it just pops back into place on its own. All right. My kneecap will do that sometimes, still to this day. I'll turn it weird and it'll pop and I'll feel it. But if I can straighten my leg out, it usually goes back in place. All right. But the very first time I did it, it was down here. No, we gotta do that manually.
Mine does the same thing because according to my doctor, the muscle on the inside of my leg isn't strong enough to hold the kneecap over.
Patellar displacement?
Yeah.
Nope. So, you might come on scene and say, your patient might say, yeah, it popped out of socket, I couldn't move, but if it looks like it's back in place, because guys, it's very obvious when something is dislocated. All right, particularly in the shoulder, there's big divots where that humeral head should be kind of connected. There's usually a big divot here. Okay. Same with a kneecap, the little triangular shape of the patella. If it's anywhere but here, you can typically see it pushing up against the skin. It's pretty obvious when there's a dislocation.
See one?
Hmm?
You guys want to see one?
Your shoulder?
Looks like that.
So yeah, there's a very obvious void space where that bone should be and it's not there. Okay?
Is Brady paying you for all this?
Like a walking billboard.
I mean, it's like, dude, I fell off a truck today and I got a pneumothorax.
Guys, you can ask too, because I ran this one guy who was playing basketball, he popped his shoulder out, and he told me, he's like, dude, this thing has popped out 10 or 12 times, and it usually goes back by itself, but this time it wasn't spontaneously reducing. So patients can have a history. Once you pop something out of socket, you're more prone to do it again, because again, those ligaments and those tendons and those muscles get overstretched, and they're not as structurally sound anymore. So you're more prone to this stuff in the future. Another one?
All of them? Every joint?
Is it within your scope to try to put a joint back in its place?
Did he ask you? Did he ask you to do
Yeah.
that? No, not
Oh. So guys, we kind of have one exception to this rule. Okay, when it comes to severe angulation and deformities of broken bones, we have kind of one exception. All right. When are we deemed, when is it appropriate for us to try to put an extremity back in its position of function? All right, guys, if we have an absent distal pulse, or if we have no motor sensation, or if we have no sensory sensation. Okay, we're not gonna be like tugging on stuff and trying to like put it back into its actual socket, but we can try to place that limb back in its normal position of function. Okay, most of the time, it's not gonna work. Okay, so if you have an angulated ankle, right? If my ankle is pointing 90 degrees or 45 degrees out to the right. Okay, is it supposed to do that?
No.
No. If I don't have a positive pedal or posterior tibial pulse, or if I can't feel my toes, I have one attempt to try to grab that ankle and place it back in its position of function. All right. If you meet any type of significant resistance when you do this, guys, we're not going to be yanking on them. We're not going to be like trying to, push that thing back over. But if you are able to put it in that position of function and you don't get any significant resistance, we can try to do that, and then we will splint it in that natural linear position of function. Okay. Have you guys ever seen somebody reduce, like one of the docs reduce a dislocation in the ER? It looks brutal. There is a lot of elbow grease, no pun intended, that goes into getting these joints back into place, and it just looks excruciating.
So it's only when there's no pulse. Because I broke my leg sitting at 45-degree angle.
Nice.
But I was like, I still have like feeling my toes and moving.
Yeah, so if your ankle is jacked up 90 degrees the wrong way, but you have a positive peripheral or distal pulse, your motor, you're able to like wiggle your toes and you can feel your toes, I won't leave that sucker there.
Yeah, because they put like a hardbar and like 2 ice packs next to it.
Yep.
And then when I got to the hospital, a doctor did it. He grabbed it, he like yanked it out and twisted it and shoved it back in place.
After pain meds, right?
Yeah, well, I mean, this is like 3 hours after I've been walking. So I'm going around.
Yeah. Guys, if that pulse, that distal pulse is intact, they can wiggle their toes, they have that motor capability, and they can feel the sensory nerve is intact. You're going to leave it like that, and you're going to splint it like you find it. All right. But if any of those 3 things are not present, we have one attempt to put that extremity back in its normal position of function. If we meet resistance, we stop. We don't continue to try to put it back there, and then we'll just splint it like we find it and notate that we had absent distal pulses from start to finish. Okay. So again, that deformity, you're gonna have that noticeable gap, swelling. Anytime, guys, they try to do anything with that, even the entire extremity. Like it could be a dislocated shoulder, but even if they're trying to move their arm down here, because everything's all interconnected, so this is gonna be extremely painful. There's no way in heck you're gonna be able to get them to do this. It's gonna hurt too much and they won't be physically able to because that joint's not intact.
My question for one guy, you're in swim class, you know how you can let yourself go to the bottom of the pool and you just let yourself up and came back and his whole shoulder was out and you had to like grab him out of the water. We don't know how it happened. He went down and came up with his shoulder and hit me.
Now guys, there are, I don't know what the medical term for it is, but there are some people who just have extremely flexible joints. One girl who used to work over here, she had this particular condition, and the doctor told her, if you ever think about having children, you're going to be bedridden for like the entire pregnancy because joints get more flexible throughout pregnancy. And he would be like, you just be walking down the street and your like knee would just like totally collapse. So there are patients who have more flexible, it's something, I can't remember the name of it, but it's the cartilage is a lot more pliable. It's not as sturdy. It's not as strong. So maybe he had that. I don't know. All right, so guys, a sprain, okay, a joint's going to be twisted beyond its normal capacity, its normal function, its normal motion. You're going to see it's going to hurt. All right, we're going to see swelling. We're going to see some bruising, some discoloration. What's wrong with that foot? Maybe down here? So yeah, guys, sometimes it's mild, sometimes it's severe. Sometimes it will be very hard to get like a distinct physical standout, like this up here. I would have to compare it to the other
It's
side.
supposed to be like, yeah, yeah, you can't see it on there at all.
Oh, it is bruised.
Huh. Okay, well, your slide's more obvious there's a bruise, okay? But it can be mild, it can be significant. Again, there's gonna be several times, guys, we're not gonna be able to determine, is this a sprain or is this a fracture, right? Because you think if somebody's ankle is super, super swollen, black and blue, very painful to the touch, that they're really gonna let you do that pressure test? No, right? So there's gonna be some times where we're just gonna check the PMS, make sure it's intact. We can ask them questions. Are you able to walk on it? Can you bear weight on it? Are you able to like move it around freely type thing? But there are going to be some times that we're not even going to be able to do like a hands-on physical assessment because the patient's just going to be like, dude, that hurts. Don't touch it. Get away from it. Do I really care if it's a sprain or a fracture? How am I going to treat it? I'm going to splint it, right? I'm going to make sure my PMS is intact. I'm going to splint it. I'm going to prevent it from moving excessively to prevent further harm, prevent further trauma, and I'm going to transport. Because guys, like I said, unless you've got an obvious deformity, you're feeling crunchy crunch, or you see a bone sticking out of the skin, we can't 110% certainty say, yes, it's a fracture, or no, this is just a sprain. Could be one, could be both, could be, either one. Guys, sprains and strains actually take longer to heal than a broken bone itself. All right. So a sprain is where the joint is overextended. A strain is going to be where the muscle, because you typically get both with the mechanism of what happens because the muscle does help keep that joint intact. But a strain is going to be the tearing or the hyperextension of the muscle involved in that particular area. How are these going to present? Swelling, bruising, painful to touch. Okay, so again, we might not be able to differentiate sprain, strain, or fracture, but we're going to treat everything the same.
Are they typically less able
Typically, if it's a significant fracture, they're usually not able to bear weight on it. But if it's like a small hairline fracture, it's very possible you could walk around on that.
So you can't diagnose between a sprain and strain just by fracture. Ooh, nice.
What do we do with amputations? Partial or complete? Okay, so first we're going to do what? Put a tourniquet on if necessary, right? Control bleeding. All right, and then what are we going to do? If we can find a piece that's completely amputated, we're going to grab it with us. We're going to wrap it up in what? Moist sterile dressing. Bring it in and say, hey, good luck, doc. Hopefully you can put it back. All right, what do we do with this still attached part?
Sterile dressing?
Yeah, it just depends, right? For this, what would we put on this? Dry dressing. That's just soft tissue. Right? Do you see any bones? Any ligaments, tendons, anything crazy like that? Dry dressing. We have significant underlying structures, moist sterile dressing, dry dressing on top of that. Okay. Yeah, I don't know. I think it's
I
just
got a
like
story for you about a guy.
this meaty part right here, right before it got to the midline. I can't tell if that's like glistening from the flash of the picture. I don't know. Okay. Treat the soft tissue injury appropriately, moist versus dry dressing. Try to bring the amputated part back to the hospital. What if you have a partial amputation? What are we going to do with the rest of the limb? Definitely not shears. So obviously control bleeding first, right, guys? Because probably at that point we're probably going to be putting a tourniquet on. If I have like half of my arm hanging off, right, an artery somewhere has been compromised. But yeah, guys, we're going to grab the remaining part of that limb that's still attached, and we're going to carry it as it's still attached, like as if it were still attached, right? We're going to move it in unison, cover up any significant exposed structures on the part that's still attached. But usually we try to put it as close to that normal position of function and just blend it all together so we restrict future movement and motion. Okay. You gotta treat it like it's whole unless it's completely amputated. So again, guys, if we have an open fracture, just like if we had like an avulsion or an evisceration with that soft tissue, if we have any significant debris in that open fracture, what do we need to do before we start dressing it? Get some sterile water, try to wash out the big chunks, right? When they're going to need to go to the OR and have like an actual surgical debridement. But for the majority, try to get most of the debris out from the injury so we don't aid what? Infection. Okay. Golden hour, especially for significant orthopedic issues, if we have any type of complete or partial amputations, what's the golden hour mentality?
Time is critical, trying to get into the hospital.
Sometime you don't have to see.
Time you get the ball.
From the time that the event occurred, from the second they had that significant injury happened to getting them to that hospital, getting them to that end destination treatment, ideally, hopefully within an hour, so they have the best chance possible for having any type of tissue or appendages reattached. Does ABC management change? Does controlling bleeding like life threats, does that change no matter what's broken or amputated? Where are these patients going? Trauma center.
Leading question regarding fractures. If the problem is like a significant fracture in like a femur, which is epifemoral, do you still tourniquet that?
Is it an external bleed?
Yes. Let's just make it simple.
So if we can determine where, like in the shaft, that the femur is broken and it's not broken, like high and tight where we need to place that tourniquet, then yeah, I'm going to place a tourniquet because my patient's going to bleed out if I don't. Right? I'm only going to cause further damage to the bone, which maybe cause them to lose a leg, but did they die? Right? We've got to stop what's going to kill them first.
What if it's closed?
We don't place tourniquets on internal bleeds. Because it is possible you could have a closed fracture that nicks that femoral artery. How might we be able to tell that we've got some internal bleeding going on with that? Okay, significant swelling, discoloration, probably loss of that distal pulse, right? Because the blood flow is no longer going to the rest of that limb. Depending on how significant the bleed is, maybe signs and symptoms of shock. But yeah, if it's an internal bleed, we don't place a tourniquet for that. It's only external.
Do we do fractional sports?
So guys, what are we going to reassess Q5 or Q15 with these patients that we're dealing with these strains and sprains and fractures and placing splints? PMS. Because what's possible we can do while placing a splint? We can make it too tight, or the position that we put the extremity in to splint it could compromise any type of blood flow, could pinch off a nerve. All right, so we definitely have to reassess that PMS for sure. That's going to be the reassessment of the intervention when we splint. Hey guys, we're going to talk about splinting after this is over. All right, guys, another obvious, and I think there's a picture a little bit later on, sign that we have, oh wait, hold on. Nope, we'll come back to that. Pelvic binder. All right, well, I guess we'll get to that later. Sorry. There's also a picture when we talk about pelvic injuries. Can you guys really put a splint on the pelvis? Not really. All right, so there's an actual piece of equipment there's different types of makes and models of a pelvic binder, or we can improvise and place a pelvic binder on a patient using what do you think?
A blanket.
Jacket, preferably a sheet or a blanket, something that's got wider diameter. But yeah, we'll get to that in just a second. Yeah, guys, if we have a fracture or a strain or sprain of any capacity that does not have a pulse, right? We tried our one attempt to put it back in that position of function. It didn't work, and we still don't have a pulse to that limb. Are they a high priority patient? Yes. We are going to transport them code 1, lights and sirens, back to the hospital because it's very imperative we get them in a OR setting where they can fix this in a timely manner before we start to run the risk of the tissue to that limb dying. It's not going to be salvageable. Okay. So the clavicle and the scapula, guys, the clavicle is one of the most easily broken bones in the body. There's not a lot of protection when it comes to the clavicle. It just kind of like juts out, right? So where do we see a lot of clavicular collarbone fractures? Contact sports, particularly like rugby and football. We see a lot of broken collarbones. It's just very susceptible because of where it is. It doesn't have a lot of cushion protecting it.
Kind of embarrassing story, but I was 15 playing on the playground with my brother. I fell and hit my collarbone. And so my mom went to the front, like, because it was a hotel. And so she went to the hotel and they're like, how old is she? They were like getting ready to call EMS. They're like, how old is she? She's like 15. So they hung up the phone. Because they're like, she's fine. And I ended up just really badly bruising my clavicle. It was Disney. They just hung up the phone. And they were like, oh, 15, she's fine.
You can still break bones when you're 15. Interesting. Guys, we might feel like that crepitus, right? We're not gonna be able to do like a pressure test, but with the pads of your fingers, remember, we're gonna push down the clavicle to see if it's stable, if it's intact. We'll talk about splinting, the position that you'll splint in that after we go through the PowerPoint. Scapula, what is that? Shoulder blade. Okay. Again, we're not really going to be able, unless it's just totally crushed or fractured in several places, we're not going to be able to palpate and really feel that fracture because it's not really as linear and as prominent as that clavicle is. How do we address that? Splint it the same way we would splint a clavicle. Okay, we'll get to that later. That's kind of what it's going to look like. Talk about that a little bit. All right, so the humeral head, again, guys, it can pop out of place, dislocation of the shoulder. It hurts. Again, you're going to see that very obvious divot where the bone should be. They're going to have almost no movement of the upper extremity. Fracture of the humerus. All right, so that's just an example. That's a complete fracture. Goes through and through. You're going to be able to palpate that if it's that drastic of a fracture. If the patient allowed you to do that staggered pressure test, you would feel crunchy crunch right there.
Would an injury like that be visible externally without touching?
Typically, yeah. Sometimes, guys, if you have larger patients who have more adipose tissue, it's not going to be as obvious. But if you have a patient who doesn't have a ton of adipose tissue, you're going to see, usually based on the swelling alone, some type of deformity or swelling in that area. Elbow injuries, common children, guys, they call it, I think it's like the milkmaid's elbow. It's another thing that commonly happens in kids. Sometimes it's because of abuse. Sometimes it's because you're trying to prevent your child from running out into, traffic. But if you're holding the child's hand and instead of like that twisting motion, you just kind of like yank up and the elbow gets hyperextended. That's common in children, whether it's an accident or it's intentional.
Ooh.
What do we call that?
Bad.
A bad day, painful, yeah, but what is that? That's deformity. That's also angulation, right? It's at a different angle than it should be normally. Our elbow doesn't bend that way, okay? It's at an improper angle. So that's a deformity and an angulation. Have you guys seen the video where of all of the people who were like arm wrestling? And like they're just so forceful, and all of a sudden it just like pops out of place, and their arm just like flops over. Ugh. Ooh, no, I can't watch anything related to knees because I get sympathy pains. Yes, I can't watch any of that stuff. Talk about splitting. Guys, the forearm, it's going to be the same. We see this a lot. How do we see forearm fractures usually? Kind of like maybe defense mechanism. You're trying to catch yourself, or if it's like a domestic or some type of assault, if you're holding up the forearm, that blunt force can cause those bones to break. Check PMS and splint accordingly. Okay. Guys, the wrist, especially the wrist fractures, are very, very hard to diagnose pre-hospital unless it's like a crazy angulation, right? Because remember, we've got several different bones that make up that wrist joint, those carpals. So almost always, it could be a sprain, it could be a strain, it could be tendonitis. Anybody ever have tendonitis? Yeah, that sucks. But you're typically not going to be able to say, "Oh, I think this particular carpal is fractured." It's not really feasible. Okay, sometimes it's obvious if like fingers can also become dislocated, especially like right here at this middle joint right here. They can kind of go either way. If we have an obvious deformity or obvious angulation, we can infer that there's a fracture. But regardless, guys, we're going to treat it the same, right? We're going to splint it and manage or monitor PMS. Yeah. Pelvis fractures. All right, guys, so again, this is why when we're assessing the pelvis, we're pushing that circular shape into itself. If everything is strong, if everything is intact, when we push that circle into itself, we shouldn't have any slack. We shouldn't be able to have like the structure of that pelvis kind of go anywhere or move. All right, so if we have a fractured pelvis itself, or if we have a dislocation, we're going to feel some crunchy crunch when we palpate, okay? What do we do with an unstable pelvis? How do we get them on the backboard? And put a pelvic binder. That's not good, guys. What's supposed to be here? Right? That cartilage, that connecting cartilage, that pubic symphysis is totally disconnected.
So you wouldn't call that a fracture?
What?
Like if you were a doctor and you saw the X-ray?
Oh no, because you can see right here,
Oh,
that's totally fractured too. It's hard sometimes looking at X-rays to know what you're looking at, but you can see here, this is supposed, this kind of crack, that line right there, and that line right there is not supposed to be there. So we've got everything's kind of shifted because that pubic symphysis is not intact, and then we've got this fracture up here.
I thought it was like the actual, just the cartilage was like torn or something.
Technically, that would be more so a dislocation
Yeah.
than a fracture. Yeah. All right, dislocation of the hip. Here's my picture. There is a very distinct, even if there's a fracture involved, guys, if that femoral head has popped out of that socket, the affected leg will be significantly shorter. Okay, because if the bone is not in its normal home, it's popped out, what are those muscles going to do? They're gonna that tension's gonna kind of pull up, and those muscles are gonna go pull taut, and it's gonna bring that bone with it. So that's why we see the shortening of that limb, of that extremity, when we have a dislocated hip. All right, and typically we see angulation of the entire extremity. Typically we'll see the entire, let's say for here, this is the left hip that's dislocated, it will be shortened, and the whole extremity will be angulating out. Like you'll see the foot kind of like pointing outward, like laterally. Shortening and angulation of lower extremities, definitely. I probably, unless that is baseline for my patient, for whatever reason, I don't even need to palpate the hip to tell me that we've got a significant dislocation.
The medic that was teaching my Wilbur class told us a story about a dislocation, and it was like on one of his expeditions. He didn't do it, but like his partner put it back.
Okay.
But they didn't secure both of his testicles beforehand, and some way or the other,
No,
his testicle ended up like
No.
in the joint.
no.
Yeah, and so they went back in, and then he just started screaming. And they were like, well, that's the opposite of what you're supposed to do. And then he just didn't stop screaming.
No. No.
And he got to the hospital, and they're like, yeah, we can't just like pull it back out and retrieve that. So,
You better do something.
so they just cut it off and retrieved as much as they could. Crazy. So he was like, yeah, you're never going to do that.
You know me both of
You're
them.
gonna do that.
Oy.
Okay.
Okay, so can we splint a pelvis?
We can do that.
Not really. All right, so remember we talked about that pelvic binder. This is just going to be showing you, it's a very quick video. Guys, we typically always will do this with a sheet, like an extra sheet we have on the truck or on the stretcher. Because what are we doing when we put this binder on? What do we want to prevent from happening? Any further movement of that extremity, that femoral head that's popped out of socket, because what can happen? We could damage nerves. We could also damage those great vessels, okay? So we're not trying to put this back into place. We're just trying to make it nice and snug and nice and kind of secure so it doesn't jostle around and cause any further damage, all right? So typically, we do this with extra sheets or blankets on scene. You can, I guess, in a pinch, do it with like a jacket, but we want something that's wider, if at all possible.
Sure that's a bleeding edge, right edge.
Probably want to stick it under this aspect.
We
of
took
probably
and also, take fluid, just make sure it's.
So you guys notice they thread it through the bend of the knee, right? We don't wanna like lift the patient's hip up and put it directly up underneath that because we would be moving it too much. But just put it up under the knee, make it pull out all of the slack, and just as controlled and as smoothly as possible, bring it up underneath the patient's hips. You're gonna pull out all the slack, make it nice and tight, and then you're just gonna kind of tuck it into
Make
itself.
sure that's the edge, right edge.
We just wanna keep that constant, just snug aspect to that pelvis.
So why don't they tie that in a knot as opposed to shoving it between those legs?
So why don't they tighten it up? Cause
We talked, and we'd also,
usually if you tie it in a knot, you're gonna lose some of the tautness of that little like circular twist motion. But yeah, and also too, guys, when we talk about splinting, we always wanna have what? Kind of like a quick release component, right? When you tie your splints, you're going to be tying them in bows, not in knots. Okay, because if something it just goes drastically wrong, or we need to quickly remove the splint to do whatever, or if the splint is causing further harm and we need to like discontinue that intervention, it needs to be done in a very quick fashion. So just pulling it out from untucking itself is a lot quicker than undoing an actual knot. So we'll talk about that when we actually play with it. All right, femur fractures. All right, guys, femur is a very long bone, right? Longest bone in the body, so it can be fractured in several different kind of aspects of the shaft of that bone. So that's the first one we're talking about. Typically, this is going to be more towards the proximal, more towards the head of the femur. We see this more so with patients who have the osteoporosis, the brittle bone disease, just the integrity of where that connects is not as strong. With this, we'll also see the rotation and we're going to see the shortening because the elongation of the shaft, especially if it's right around the femoral head, is not going to be as intact. So we can see the shortening and we can see the rotation of that. So sometimes, guys, it's very common to confuse like a broken pelvis or a fractured pelvis with the proximal femur fracture. Okay, but we'll talk about that in a second. Shaft fractures, these are a lot easier to notice. They're a lot more prominent with their signs and symptoms. This is also where we start to see some significant compromise or potential for compromise of the blood flow, where we start to impact that femoral artery because of the bone shards. We'll talk about a traction splint in just a minute. Okay. Bad day. Is this an open or closed fracture? That's going to be an open fracture. Okay. This appears to be a closed fracture. All right. So here's the femoral head going down to the kneecap. There's butt cheek right there, right? And we see this fracture right here. All right, now we're going to talk about traction splints. We're going to watch the video. You guys are going to practice with them. They are totally within your scope to use. They are great to utilize in a patient, but they have very strict parameters as to who you can place a traction splint on. All right, does anybody know what a traction splint is besides Amy?
The way it's positioned puts traction on that bone, kind of like holds it off the end from like bone.
It looks like a torture device, but it provides a lot of pain relief for patients. Okay, guys, we can only use traction splints on an isolated, closed femur fracture. The way that it's placed, and you'll see it in this video, and you'll see it when we play with it, you cannot have any other injuries to that side of the lower extremity. You you have to have it completely intact. Like, let's say I break this dude's right femur or chick. I don't know. This person's right femur is obviously broken. Okay, she's not a candidate for a traction splint just based off the fact of what? It's open. All right, so you have to have an isolated closed femur fracture. You have to have a stable pelvis, obviously bilaterally. Okay, you have to have an intact patella. You can't have any injuries to your tib fib, and you can't have any injuries to your foot or your ankle. It has to be an isolated closed femur fracture.
I feel like that's not good.
That is just like a very random distribution of blunt trauma for you not to have any other surrounding injuries. So if you do have a patient who has a closed, just the femur's broken, the hips are good, the knees intact, the tibia, the fibula, the ankle, and all aspects of the feet are good to go, we can put a traction splint on. Okay, so why do they call it a traction splint? All right, so if we have that closed femur fracture, okay, typically what causes the most pain is these ends of the bone rubbing up against each other. All right, so if we have like a complete fracture, when we put the traction splint on, we actually kind of crank a piece of the equipment down by the ankle and it pulls the leg like this to the point where those bones, the ends of those bones aren't doing this to each other, and it doesn't hurt the patient nearly as much anymore. You can have a patient screaming in pain with a closed femur fracture. When you start cranking that traction splint, when it gets to the point where the bones aren't doing this, you're like, oh, that feels better. Obviously doesn't feel great, right? But it's not that agonizing pain anymore because we've kind of displaced those ends of the bones from touching or rubbing up against each other. Okay, so it's great to use, but it's very rare that we have that isolated closed femur fracture.
Apparently that's like super common on ski resorts.
Huh.
So much so that they like always carry.
Anything else?
This is the application of the hair traction splint. Hair traction splits are designed to be used for mid-shaft femur fractures only. It should be about a hand width below the pelvis and a hand width above the knee, somewhere in here. There could be no other associated injuries. No pelvic fractures, no knee injuries or dislocations, no tib fib or ankle. It's only designed for a mid-shaft femur fracture. First thing you must do is stabilize the fracture site, expose the patient's body by cutting off the clothes to the affected site, remove the shoe, sock, and then check for pulse, motor, sensory. Do you feel this?
Yes.
You want to first apply the ankle hitch.
Well, that black on black is super easy.
I know,
right?
So, are you gonna want just like press down?
Yeah, that's not stabilizing the femur, by the way. Just like placing Jesus' hands on there.
And we'll measure the traction splint on the non-affected side. This is because the leg may shorten with a full femur fracture. We're going to measure from the backside around the level of your pocket down to about 6 to 8 inches below the ankle hitch here.
You guys, that little curved
Now lock
piece
into position
at the top is gonna sit right underneath the butt cheek.
and prepare for traction.
So there's one major problem. Just one, you say? happy with this video?
Okay. Please come around, support the leg.
Okay. When we lift the extremity up to put the traction splint up underneath it, where's the freaking fracture? In the femur. What is not being supported in any capacity? The femur. Alright, so guys, yes, you are gonna have to pick up the ankle to like slide it up underneath the leg. Somebody grab an ankle and then somebody also, you can, double fist it, right? Ankle with one hand, femur with the other hand. Make sure that you're supporting the femur when you lift it to place the traction splint, because that's where the fracture is.
The first strap always to go is the ischial strap. Next, we apply traction. Placing the S ring into the D ring and trying to tighten it out.
Okay, so see they're pulling traction. Have a little kickstand.
There we go. Apply enough traction so that the leg is straightened and there is some relief. Finally, you may apply the straps, avoiding the fracture site and avoiding any joints.
They're not wearing like white pants.
Check for pulse,
And
Motor.
black socks.
censored. Most patients with a mechanism enough to cause a mid-shaft femur fracture may also need to be immobilized using a long spine board. You can use the two together.
That was from 2013?
Yeah. That was like a shade of basement camera or something. I don't know.
So if we call it like some abrasions or lacerations.
Yeah, guys, if you've got any like abrasions or lacerations to that affected extremity, it's structurally sound. We can apply that dressing. Try to avoid putting those straps like directly on top of those soft tissue injuries, but we can still use a traction splint. Just place those straps accordingly. Okay. Again, guys, remember your knee is a joint, so it can become displaced. But the patella itself is a what? It's a bone, so that can become displaced. It can also be fractured. All right, so keep that in mind. Any type of ligament or tendon injury, swelling, bruising, immobility of the joint, kind of a common theme with all of these orthopedic injuries, right? Dislocation of the knee. So again, guys, you have got that big, you hear about it all the time, that ACL, LCL, MCL, PCL, all of these major ligaments that hold your knee joint together, they can become they can become torn. All right, so if that's the case, we run the risk of having that total linear appearance and structure of that lower extremity being kind of jacked up right there at the knee if we have all of this torn. The only one that I didn't tear was my LCL. I know, hung in there.
Oh God, what is that?
That's a knee. This is thigh, this is patella, and this is all of those ligaments severed, and this is the lower half of the leg.
Looks like that Photoshop effect.
The liquefy or the whatever. Yeah, mine wasn't that bad, but it looked kind of like that. Except my kneecap was like down here.
My kneecap went all the way behind me.
Oh, nice. What'd you do?
I was dancing. And a bar.
Oh, boy. Guys, can we use a traction splint on that knee? No, definitely not. Again, guys, we have one attempt to get that knee back into the normal position of function if what is impaired?
Yes.
PMS. If we meet significant resistance, we're going to splint it like we find it. Okay? Hmm? No, because the displacement of the patella is not really going to cause any PMS deficit. Okay, so again, we can have all of these stay intact, all of these ligaments, but we can just have the patella pop out of place. Again, they typically reduce. Okay, but we are not going to put it back into place because, like I said, typically we don't have PMS affected by just a patella displacement. So normal, right? A little bony triangle, not normal. This one's totally dislocated off to that lateral side. Bad day? Open or close fracture? Guys, how would we splint this? So you would have to, as gross as it sounds, come grab this part that's dangling and lift it to where it would be naturally straight in that position of function and splint it in that position of function. Be mindful not to have the bone ends scrape up against each other, but you would have to splint this in the position of function. You can't just like let it dangle all the way to hospital.
Or like until you hit resistance.
Until you hit resistance. But yeah, I wouldn't really pull it out and then up. I would just kind of maybe like pull it up and like.
I've always wondered, like with fractures like that, like sometimes when you pull traction, like does the bone just not go back in? Like, is it possible that like the bone could be like sticking out farther up, and you're able to like pull it back in?
Oh yeah. That's why we're not trying to get those bones like linear, if you will. We're just trying to get the extremity as a whole linear in that position of function.
If you like straighten out, just like still.
Yep, we just splint it when we get it straight.
Put a dressing over it.
Guys, ankle injuries, it can be something as significant as that, or it can be something as minor as that. All right, so remember, unless we have an obvious deformity, if we have obvious crepitus, if we have an obvious angulation, it could very well be a sprain or a strain or a fracture. We're going to treat it all the same. We're going to check PMS and we're going to splint, right? Not a whole lot we can, because that could be anything. Foot injuries. It's not really a good funny one with the office where they do parkour. Do we want to watch it? Yeah. So again, guys, remember when we talked about trauma overview, that energy can only be transferred, right? Not destroyed. So sometimes if we are jumping and we land on our feet, we would expect just an ankle injury or a foot injury. But because of that momentum of the patient, it can go upward and it can cause spinal cord injuries. It can cause pelvic injuries. So keep that in mind, that momentum of the end. My 3-year-old watched this episode and he jumped off the couch and he yelled parkour.
This jar is filled with stars representing all the reviews for a competing mattress company. Pretty big deal, right? Wrong.
This is parkour. Internet sensation in 2004, and it was in one of the Bond films. It's pretty impressive. The goal is to get from point A to point B as creatively as possible. So technically, they are doing parkour as long as point A is illusion and point B is possible.
Oh my God.
Okay, we all go together, or we go one at a time. Here it is, here it is. Truck to refrigerators to dumpster, 360 spin onto the pouch, backflip gainer into the trash. Yeah, parkour, parkour.
I've never watched that show. I'm gonna need to do that.
Yes,
Very fantastic.
you're missing out. Guys, your RICE acronyms for strains and sprains: rest, ice, compression, elevation, and splinting. That compression and splinting kind of goes hand in hand. We can put a cold pack on the affected area to hopefully reduce the swelling, hopefully reduce some of the pain. Our main goal is going to be splinting these affected limbs, joints. Talked about amputation. Do not sever any partial amputation on hands. All right, so compartment syndrome, guys, we talked about this is particularly secondary from what? Usually a crush injury. What's happening? Okay, so build up of pressure, right? The amount of swelling is exceeding the surface area for that particular area of the body. All right. So we have that crush injury happen because of that swelling. Now, what can happen because of this? Hold on. What can happen because of the excessive swelling?
Loss of blood flow.
Loss of blood flow, right? That pressure is accumulating. We start to keep off the vessels that are going to that particular area. We can start to have the loss of blood flow. We can lose sensory. We can sometimes lose motor. Okay, guys, this is going to be significant swelling, significant pain. What is the end-all be-all treatments for compartment syndrome?
What did it mean by power?
Huh?
Power.
Just the presentation of the skin.
Like what?
Typically, it's going to be pale
Okay.
because of all of the pressure is kind of pushing, is kinking off the blood flow. It almost sometimes has like a blanched appearance. Or it could be significantly flushed, just depending on what stage it is in the swelling. Guys, what's the end-all be-all treatment? Can we do the end-all be-all treatment? No. Fasciotomy is the end-all be-all treatment. Okay, guys, what happens here? Remember going back to the skin structure. So remember that the kind of it's a bad, I mean, not really. It's the analogy that I gave you guys is like the sausage casing that helps cover and kind of contain the muscle to help it adhere to that the dermis aspect of your skin. If you guys eat ribs, and if you grilled out ribs over the weekend, and kind of that silvery film that can peel off the back of the ribs, that's fascia. Okay, so you're not really supposed to eat that; just peel it off. But that's fascia in comparison to ribs that we eat on the grill. Yeah, so what's happening here is we're having all of this pressure exceed the surface area of that particular part of the body. So what they do is they go in and they make a surgical cut down to the fascia. They cut open that fascia. They pop open that sausage casing, right? And then they have a controlled method of leaving that surgical incision open. They put like this really spongy material. It really does look like a sponge. It's got all sorts of properties in it that promote like healing and ward off infection. But they take I think it's called a vacuum or a vacutainer. They hook it up to the sponge and they create a constant suction. So any excess fluid is kind of suctioned off and put in a container. It's covered and they usually leave it open, if you will, for usually about a week or two to allow all of that tissue, so the swelling to go down, and then they go back, they remove the little spongy stuff, and they surgically close up the fascia and all of the skin.
So like after a week, we're just like put it back together.
Because the swelling's gone and that suction unit is just kind of getting all of that extra fluid and getting rid of it, so it's not just sitting there pulling.
But like the skin just goes back together. Like
No, they have to go in like surgery. They have to like suture everything
the
together.
ends of the skin though, it's not like closing off. That's great.
It's really cool. We saw a lot of that in the ICU. So here's a picture of fasciotomy. As you can see, it's a surgical procedure. So what are we looking at here? That's fat tissue, okay? So you can see this is directly, we're looking directly at the muscle. They've cut back the fascia and we're looking directly at the muscle tissue right there. They'll cut that kind of sponge to fit this opening. They'll hook it up to the suction machine. They'll put some clear, they call it tegaderm, over it to make sure it's not having like any outside debris coming in. They'll leave it a week or two. They'll remove everything. They'll go back and they'll stitch everything back together. Yeah. Yeah. Leg. Down here is going to be ankle. Up here is going to be knee. Oh, actually, yeah, here's the bend of the knee right here. Huh? Yeah, it's right here. Okay. All right, guys. So for splinting, there's a couple of baseline rules, but the rest of everything else you can improvise. Okay, guys, you have two particular sheets when it comes to these skills for lab practice, for instructor checkoffs, and for registry. Okay, you have a long bone immobilization sheet, and you have a joint immobilization sheet. Guys, what is the end all be all goal of splinting? Okay, prevent any further motion, so we prevent any further harm. Okay, so do you guys have those sheets in any capacity? There should be some over there again. Joint and long bone. Yep. And actually, guys, I'm going to pause. I'm going to go get some more. Okay. All right, so guys, what's the main purpose of splinting? What are we trying to do? Immobilize. We want to prevent any further movement so we can prevent further damage. Okay. So what's your first step if it's a bone or a joint going to be? BSI, scene safe, right? How are we ideally going to be splinting these extremities? In the position of function. Sometimes it's going to be the position of comfort, right? But typically when we splint anything in that upper extremity, we're usually going to have it kind of in this position, right? Especially when we talk about the knee. I'll show you guys the knee. There's a particular position of like comfort when it comes to the knee that we can work around, but ideally in the position of function / position of comfort. Okay. So based on your sheet, BSI, scene safe, you're gonna have your partner do what? Okay, so read your sheet. So manually stabilize that extremity, right? All right, so after your partner manually stabilizes that extremity, what are you gonna do? So you're gonna assess PMS, guys, because yes, we're gonna be restricting motion and we're gonna try to be preventing further harm, but what do we have to do in some capacity to get that done? Just like backboarding, we are doing this in a controlled fashion. We're putting them on the backboard to prevent further harm, but we're doing what to get that accomplished? We're moving this patient, right? So in order to splint, we are gonna be manipulating that extremity. Why do we get a baseline PMS before we start doing anything? Okay, so I want to see, hey, my patient doesn't have a distal pulse to begin with versus, hey, my PMS was intact, but then after I splinted, that distal pulse was gone. I want to see if it's, I caused any of those PMS deficits throughout the course of applying a splint. Okay? So BSI scene safe, have your partner manually stabilize the extremity, assess PMS, and then you're going to start splinting. All right? It doesn't have to be pretty, right? Nothing about splinting is going to be pretty. I don't care that it looks nice and neat and uniform. It could look like teetotal crap, but as long as it does the job, I don't care. All right? It doesn't have to be pretty, and more is always going to be more. What does that mean? But in what capacity? Okay, so guys, we're going to be using splints, rigid splints in some capacity. We'll talk about those, ace wraps, and triangle bandages to be splinting. Okay, especially when it comes to those ace wraps, the more you apply, obviously we're not going to try to cut off circulation or impair PMS, but the more you put on there, the more snug that extremity is going to be, the less likely it's going to move, and the less likely we're going to cause trauma. Okay. Guys, there is no absolute right way to splint. You can improvise. You can do it 12 different ways. All right. At the end of the day, if it does its job and it doesn't cause any further harm, I don't care what it looks like. I don't care what approach you took to splinting. If you don't negatively affect PMS and you effectively immobilize that part of the extremity, I am good with however it looks. Is that fair? Okay. So you'll immobilize, and then after you're done immobilizing and splinting, what's the last step you do? Just like backboarding. Reassess your PMS, because we want to make sure that we didn't cause any deficits in the PMS. What are some things that we could do that could cause? Yeah, guys, you could put it on too tight. You could constrict that blood flow. We can affect the pulse. We could have it kind of crimped up in a position that's too tight or something along those lines where we're putting pressure on a nerve ending. So we're going to assess PMS first and last, just like backboarding. You can do it 20 times in between. I don't care. But if you don't do it first, and if you don't do it last, it's a critical fail. Okay? Fair enough? There's no exact right way to splint. It doesn't have to be pretty, and more is more. Okay? At the end of the day, if that area is mobilized and it didn't negatively affect PMS, I don't care what it looks like. Fair enough? All right. So guys, there's different things we're going to use as splints. These orange ones that I've put on the table are the most common, especially you're going to see these here at Grady. If you pick these up and feel them, they're made out of like a corrugated, okay, this one's cut open. All right, so typically they're made out of like a corrugated cardboard, okay? There is a firm side, and then there's a side that has padding. All right, where do you think we're going to put the padded side? Towards the bone, right? Whatever we're trying to splint, okay? They're typically the corrugated cardboard because what can you do? Let's say I've got this size splint and all I need to splint is a wrist. That can happen? You can kick through it. You can manipulate the size. You can, yeah. You can break it and make it smaller with that cardboard. Now, when that happens, if you do have to break it, I would suggest getting grading tape and kind of taping up the ends that was severed. So it's not rough, it's not poking the patient. But you can typically manipulate the sizes, the length of these splints. Okay, this is one thing that we can use to splint. This is very versatile. This is another example of something you might see on a truck. What is this? Cardboard splint. All right, so depending on what you're splinting, you're going to place the padded sides towards the patient's bone, and then you'll just kind of pull up the sides of the cardboard and tape it nice and snugly, or secure it nice and snugly. All right, what do you think these are? Sheep. All of this stuff is disposable. Okay, you're not going to reuse these things because they're going to come in contact if there's blood or anything like that. But this is an example of something you might see on the truck. You also might see these called SAM splints. These are great. They're more expensive, but they can actually mold to whatever shape you want them to be. All right, so particularly when we're doing like the wrist, we can actually make like kind of a hand grip here. We can kind of bring it up around the bone itself. Then we can secure this. These are flexible, they're pliable, but they're more expensive. So typically don't see these as much as you do just the hard, rigid splints. And what can you use for a splint? What if you have to improvise? What if you don't have any of this on your truck because you did not check your equipment before you went in service?
Wood, anything like metal.
Anything that is flat and firm. All right. I used a broomstick one time as a splint. You could use a significantly sized branch. You can use whatever that you have on scene that is appropriately sized, that is flat and is firm, so you can but secure the bone or joint with. Okay. Doesn't have to be the splint. It could be something on scene that you're improvising with. As long as it's flat and it's firm, you can use it to splint. Fair enough? Okay. Everybody with me so far? Okay. So I think what we're gonna do, we talked about the general principles of splinting. I'm just gonna start showing you guys how to splint different areas. Is that okay? All right. So let's everybody come gather around the campfire up here. Okay, so again, we're going to use splints, we're going to use ace wraps, and we're going to use triangle bandages. So I had on y'all's table triangle bandages that had already been opened and been used. Okay, when you have them on the truck, they're going to come pre-packaged in their little own Ziploc bag. And these are going to be nice, like the ones that y'all use are going to be all ragged and all this stuff. But they come out of the package. It's kind of like a cheesecloth material, kind of like a more secure 4x4. All right, they're going to come out of the package in a very elongated triangle shape. Okay, go ahead and do yourself a favor. This point right here, go ahead and tie a knot in that point. So that way, especially if you're having to use this as an actual sling to hold and support the upper arm, the upper extremity, you just created a little pocket for the elbow to sit in. So it serves as kind of like a hammock. Okay, if that knot is not there, it's not going to do anything to try to hold that upper extremity up. Okay, so triangle bandage, take it out of the package, nice and clean. Go ahead and form a knot, especially if you're using it as a sling. If you're not using it as a sling, if you're just immobilizing anything for the lower extremity, you don't have to tie the knot. You can just pretty much use this as what? Rope. Pretty much. Okay. Notice in here too, they come with what? Okay, little safety pins. That is because at some points, especially when we're doing it, utilizing it as a sling, there's some slack that might be in the material, and we want to try to get as much slack out as possible so we can take the extra material and kind of like twist it, and we can actually safety pin the material to the patient's shirt so the slack is gone. We'll show that in a little bit, but that's what these safety pins are for, is to try to get the slack out of the sling. All right. Who wants to be broken? All right, so let's start, guys, with the upper extremity, okay? Pretty much, there are several different aspects of the upper extremity. We're going to do the same approach to splinting. We're going to have the same kind of concept to splinting, okay? Tell me some bones and some joints in the upper extremity that can be broken / compromised. Okay, so let's start up here. Clavicle, right? That's a long bone. All right, what else? So, yeah, technically the scapula. What about joint? What is this? Your shoulder. Just your shoulder. Humerus, elbow, radial, ulna, wrist, and technically, what are the finger? Okay, technically they're long bones, so all of those are fair game for upper extremity. If I say, oh, your patient's complaining of pain to the right clavicle, you got to know how to splint it. Okay, so let's start with one of the sheets. For example, the humerus. The humerus is a what? A long bone or a joint? Long bone. Okay, so based on that sheet and based on the guidelines to splinting, what has to be secured and immobilized for it to be considered immobile? The joint above and below that long bone. So at the end of my splinting attempt, I have to make sure that this shoulder is not able to move freely and that the elbow is not able to move freely, right? Because if I can freely move my shoulder or my elbow, do you think my humerus is properly secured? No. All right, so for example, the elbow is a joint. What do you think has to be secured for a joint? The bone above and below. So if I'm splinting his elbow, I have to make sure that my humerus is immobile, it's not able to move, and I also have to make sure my radius and my ulna are not able to move freely on their own. Okay, so again, guys, check PMS first and last. More is more. All right, at the end of the day, that long bone or that joint should be nice and secure, but then you need to step back and say, okay, I was immobilizing the elbow. Is my humerus good? Is it moving? Is my radial and my ulna good? Are they moving? If you can say no, they're not moving, okay, it's properly secured. Does that make sense? So just remember, it's opposite. For a joint, the long bone above and below have to be immobilized, and for the long bone, the joint above and below have to be immobilized. Fair enough? Yeah. Okay, so his humerus is broken. All right. Where's the really short one?
Out.
All right, so guys, technically you can use like an actual splint on the humerus, right? I can protect it. I'm going to put the padded side towards the arm itself. But again, at the end of the day, if the elbow and the shoulder are immobilized, it's technically secure. Okay, so BSI scene safe, right? I'm going to have my partner manually stabilize the upper extremity. Okay. So we want to try to put it in the position of function / comfort. Guys, the more you can have this upper extremity closer to the core, what is the core of your body also going to serve as? A splint. It's going to further restrict motion if we can secure the upper extremity to the body itself, right? So we're going to try to do, if that is a position of comfort for my patient, I'm going to have my partner manually stabilize it. I'm going to go check PMS. Do I have a positive radial pulse? The proctor will say yes. What finger am I touching? Give me thumbs up. Okay. Remember too, guys, when you're assessing PMS, there is a difference between I don't want to move my toes or my fingers because it hurts to do it, and I physically can't move my toes or my fingers. Does that make sense? You can have a patient, you can say, hey, can you wiggle your toes for me? No, it hurts. I don't want to move it. I understand it hurts, but I need you to give me a little bit of a wiggle just so I can make sure that that pathway is intact. Okay, that's different than saying, hey, can you move your big toe? I'm moving it now, and we're looking at it and there's no motion, right? Pain and physically not being able to are two different things. Does that make sense? All right, so I could put this here to further protect my humerus. I'm going to use my triangle bandage as rope. I'm just going to secure it at the top and at the bottom. Again, guys, you want this to be nice and snug, and you're also going to tie it in bows. You are not going to secure these in knots. Because remember, we need a what? We need a quick release. I'm going to get this other triangle bandage, secure the bottom aspect. Guys, more is more, okay? I don't care what it is in the upper extremity, you should always do what two things? It's an upper extremity. Okay, so to splint it to his body, how do you do that? Sling and swath, all right? So in order to make sure that elbow and that shoulder aren't going anywhere, I'm going to sling first. Remember, we get that triangle bandage, we tie the knot in it to create the pocket, the little hammock, okay? So I'm going to make sure I put the bend of his elbow in that little hammock. Guys, don't put the actual splint itself in the hammock pocket, all right? So the bend of the elbow, and then I'm going to kind of crisscross this across his body. Guys, when we splint, the entire length of that upper extremity should be covered, right? I don't want you guys putting a sling on. I don't want you putting a sling on that's just going to cover that much of his forearm. Because exactly what just happened. We're placing this sling to support the weight of his entire upper extremity. So in order to do that, I want to make sure it goes the entire length of his forearm to make sure that we're not going to have any of that weight flopping everywhere. All right, so I'm going to sling. I'm going to tie again a nice little knot up here. Okay, this is the point where if I had any excess material up here, so see how this is kind of having a little slack right here? You can either take this material, kind of knot it up and tie a knot to itself, or this is where you could use those safety pins, right? I'm going to take out the slack in the material, and then I could safety pin it to a shirt. Because I want that just to be very strong. I don't want there to be any slack, so this could possibly flop down, right? When you're going through these checkoffs, you can verbalize, hey, I notice that there's slack right here. In real life, I would either tie a knot or pin it to a shirt. If you tell me, hey, I would do this in real life, that's okay. You don't actually have to pin it or tie it in a knot. Fair? All right, so that is the sling, okay? Technically, based on the sling, if I took the slack out, could you freely move your shoulder? Like chicken wing it. Okay. Could you move the elbow? Okay. So more is more, right? Here's where the swath part comes in. So once I have it slung. All right, here comes the swath part. All right, so I'm going to take an ace bandage and I'm going to, guys, if we can pinpoint exactly where in the shaft the fracture is, we're going to avoid doing what? Putting direct pressure on that particular area. Okay, so let's, for the nice purposes of checking off and learning splinting, we'll just say everything can be mid-shaft. Okay, not going to be that way in real life, but you're just going to have to work around the particular areas of pain. Okay, so I'm going to go on top of the humerus. And I'm going to make sure that I'm swathing this through my patient's body. When I do this, guys, make sure you go up underneath the other arm. All right? Because what can happen if I go on top of this arm? Raise your left hand, like all the way up. All right? More slack is now created. This is not going to be secure. So make sure you're going under the arm. coming around. You can kind of view along the entire length of the forearm. And then when it comes out to Velcro, you Velcro the ace wrap to itself. More is more. Just put one more on there for safe measure. Thank you for wearing deodorant today.
You're welcome.
Then guys, this is gonna be Velcro to itself. Undo the Velcro and then turn it around and it attaches to itself. Does that feel a lot more secure than just a sling?
Yes, definitely.
All right, so after I sling and swath, get in there, check the radial pulse. Can you feel which finger I'm touching? Wiggle it. Okay. Guys, what does this cover? Do you need me? You guys hanging up? This slinging and swathing method, regardless if I have this splint here or not. All right, so let's just remove that. Oh, sorry, Josh. What all is securely immobilized right now?
Everything.
The whole side.
Pretty much everything in the upper extremity, right? My clavicle. Okay, is my shoulder moving around? Is my scapula really moving around? I can make sure I directly put more so the ace bandage on top of the scapula. All right, so shoulder. Is my clavicle going anywhere? Is my humerus going anywhere? No. All right, my elbow. Is my humerus going anywhere? Radial and ulna, are they going anywhere? No. Okay. Ideally, when we do the wrist, you like to see this is typically the position of function for the wrist. Ideally, we would have a shorter length splint, but we would do the wrist a little bit differently, but you can sling and swath the wrist after you place the splint on as well. Okay, I'll show you guys how to do the wrist, but this sling and swath method covers pretty much everything with the exception of using this for support of the radius and the ulna and the wrist. That's what you need to do for everything in the upper extremity. Fair enough? Okay. Questions on that? Anything to add?
If it's a broken bone, you need a stick. If it's a joint, you probably don't. I mean, the wrist, but yeah.
The wrist typically you do.
So if you're like, do I need a stick? Is the bone broken or is it already straight? If it's not straight, tie it to something that's straight. It's super simple. And the patient's literally in a different shape than what they should be. So there's no one right way to do this. Because if the elbow only comes down to here because everything's been crushed, it's going to be a little bit different than if there's extension or rotation and the joint is off. So it's kind of the default. You adapt from there.
Okay. So end all, be all position for everything in the upper extremity is slinged and swathed. So now I'll show you guys how to use the splint itself for different bones and for the wrist. Okay, do yourself a favor. I'm not going to do it every time right now, but when you, you're still, you're still broken. You're not. With the ace strap, guys, re-wrap them every time and make sure that the Velcro, you start with the Velcro on the inside. So that way when you get to, okay. That way when you get to the very end, the Velcro is exactly where it needs to be to make sure it sticks to itself. Okay. So for the radius and the ulna, guys, same thing. BSI, scene safe, partner, hold my arm in the position of function, check PMS, but then I'm going to attach, like Brett said, if a bone is broken, you need to make it flat and linear again, right? Yes.
What if people like they flatten like a ball?
Yeah, totally. That, yes.
Something like this. Yeah.
Oh, like where you grip
so,
it?
yeah, you can have it like this because it's easier. You just need one piece, or you can put something like this in their hand.
So here, let me
That's
show
going to have all the muscles in a neutral position. This and this requires a lot of flexing here. If you relax, your hand kind of goes into this position. Like if you look at a classical painting, it's usually the grip they have. And so that there holds your muscles. If they're tense, they're gonna pull the wrist this way, or this way, or really it's just that way. So just relax in that position here, okay?
So guys, make sure if you're placing a splint because we have a broken bone, we're not putting any direct pressure on what? So if we know where exactly in the shaft of the bone the fracture is, we're not putting direct pressure on that, but also what? Joints. We don't want to ever put any direct pressure on the joint itself, because if the elbow is not already jacked up and I put direct pressure on the elbow, I can cause trauma. Okay. So for here, partner, I need you again. Sorry. Again, guys, use it as rope. Attach the board. We're going to be nice and say that everything is midline, right? So I can attach this here. Using a bow the whole time. And then I need to do what? Go ahead and sling a swab. More is more. Okay, that way I can really secure that elbow so the elbow is not freely moving. The wrist is kind of secured, being tied to the board itself, but sling and swab. All right, so radius, ulna, you need a board, and then sling and swab. Now the wrist. BSI, seem safe. Partner hold this, check PMS, right? Typically, guys, you can do the ball grip like we were just talking about, or you can just have the fingers go like extend beyond the board like that. Okay, so now what do I need to make sure is nice and secure? The bone above and below the joint, right? So I'm going to secure. You're so smart. My radius and my ulna to the splint. I'm also going to secure what else? Okay, where? So those metacarpals, right? Be very careful when it comes to this, because we don't want to put pressure on the wrist itself, on that joint, right? So just kind of making sure you're going on those long bones of the hands. Probably go around more than once. Technically, is that secure? Thank you. As long the bone above and below the wrist, immobilized. Technically, yeah, but what's one of the rules of splinting? More is more. So you could technically do it. Sling and swap it. Guys, just for safe measure, because too, if it's the wrist that's hurting, guys, what is your patient naturally going to be doing for anything in that upper extremity? They're going to be holding it as close to their body as possible, because it's less likely that it's going to get hit or jostled. Okay, that's a position of comfort. So just go ahead and sling and swath so that it's just less likely to move, and it's just a little bit more of a comfort blanket to your patient.
Plus, if say my arm is broken and I'm holding it like this, it's floppy. If I hold it like this, it's secured against my body. So even as I do this, it's not moving, the bones aren't moving. So they're smoothing it to themselves. They're just trying to express.
I know you guys haven't played with it yet, but the concept of slinging and swathing and everything for upper extremity. Is there any like immediate questions? I know it's going to come when you guys actually get your hands on this stuff, but the overall guidelines for the upper extremity. Everybody good? Okay. Lower extremities. Lower. All right, so what all am I possibly going to be splinting when it comes to the lower extremities? Okay, so let's start from the top. Am I going to put a splint on my pelvis? No. What can I use? Pelvic binder. Okay. So what's my long bone here? So femur. I might have to splint a femur. Knee. Okay. Tib fib. Ankle. All right. So, let's see. I might not have. Let me grab that one. Okay. will you toss me those?
Can't really see my legs though.
Better? All right, so guys, BSI, seem safe. We'll start at the top. We'll do the femur first. Okay, is it a long bone? Yes, so I need to make sure what is secured. The joint above and below. So the hip and the knee need to be immobilized. Guys, pretty much if you're securing a if you're splinting a femur, that entire lower extremity is going to be immobilized. All right, so BSI, seem safe. Have my partner hold it in position of function. I'm going to assess PMS to the lower extremities. Do I have either posterior tibial or pedal pulse? You'll ask your proctor that. Can you feel which toe I'm touching? Wiggle it. Okay. So guys, in order, luckily, my patient had on a belt, right? So I'm going to place an appropriately sized splint, and I'm going to try to immobilize the hip joint as much as I can. All right. So what we can do is we can just slide it through. Belt loop. Okay. And then now I'm going to take another splint, padded side towards my patient. Please be mindful of anatomy when you do this. Okay. You're good. All right. I'm going to go as high up as I can to have the entire length of the leg secured. All right. So when I do this, I'm going to use my triangle bandage, and I'm going to make sure in a couple different places I'm going to secure the splints to the leg. Highlight. And then up here, again, we're going to be nice and give you mid-shaft fracture. So let's say, why wouldn't I be using something else for this? Why wouldn't I be using a traction splint for this?
Other stuff?
Could have other stuff going on. What do you mean?
Open.
Let's say it's an open femur fracture. Let's say my kneecap is not intact. Let's say my hip or my, yeah. So this is if they're not a candidate for that traction splint, which we'll go over in a minute.
So I was just tying the knot. Don't delay transport on a critical patient to split an extremity. Tie them to the backboard. It's a giant splint.
Okay.
So if you're thinking, oh, their limbs are broken, we're going to be here 30 minutes splitting, tie them to the backboard.
All right. So can you really move your knee?
Yes.
If you wanted to.
Yes.
Right? Guys, again, you're not going to be like, hey, person's with an open femur fracture, hey, can you move your knee around? You're not going to want to, right? But because he technically can, this is not successfully immobilized, right? So I want you to mummify the entire lower extremity with your ACE wraps.
Yeah, because he can move his knee. All he has to do is pull his ankle up.
Yeah. And guys, again, we do understand you are going to have to like manipulate the extremity or the area a little bit. So as long as you're doing it in a controlled manner, you're not flopping it around, you're not just like, doing this to the patient. It's okay if there are subtle movements. All right, guys, pull your ACE wrap nice and snug. And guys, I know I just said that we're not going to put direct pressure over a joint, but what is happening right here with this ACE wrap? What's happening to the pressure? It's evenly distributed, right? This is saying if I used a triangle bandage to put that direct, just pinpoint pressure on a joint, we don't do that. But if I'm using this ACE wrap and it's evenly distributed, you can go on top of the joint. More is more. Technically, this is probably good, right? But what could he possibly do if he wanted to? Move the ankle.
Yeah. So this was tib fib too. You have to mobilize that.
Yeah. So guys, again, I'm not gonna knock you if you put more ACE wraps than necessary. feel nice and safe and snug.
Because she made a stirrup, so it's not doing this. It's just holding it nice. So if he's bouncing down the road, it's all loose. And it's fine.
All right. Recheck posterior tibial or pedal. Can you feel which toe? Wiggle it. Boom. That's a femur, splinting a femur if it's not eligible for a traction splint. Okay? You ready with that?
But for the record, if they have a broken femur, chances are they're not stable. So it's not believing the other factor is that.
When you have a hip fracture or a knee fracture, like joints are affected if you can't move. Like
Oh, yeah.
I said a minute ago.
Yes.
So if they're in
If your
shock.
joints are intact, you can use traction. That's a whole pseudo document.
Make sure this isn't too long, because when you close the door.
Yeah, and guys, when you're practicing this and when you're getting checkoffs, if it is several inches or a few inches too long, you can say in real life, I would like the splint to end right here.
Yeah,
I don't want you guys breaking these,
Right.
okay? We need these for multi-use, but I want you to tell me if it's way too long, then say ideally I would have it end right here because we don't want it jutting out past the stretcher, getting caught on stuff, you know, jostling the entire extremity.
These would be single use in the field, so you could break it, put tape over the top, so there's no splinters or anything like that.
Okay. All right, so we'll do the rest of the splints and then we'll come back to the traction system. Okay. Moving down, what's next? Your knee. All right, so let me find the mat. I think it's over there. Is that the matching length for this? All right, guys, speaking from personal experience, anytime you injure the knee, all right, the position of comfort is not going to be just straight flat out on the ground. It's just not, all right? Typically, 9.9 times out of 10, you're going to find your patient in this position, okay? So usually, that's going to be the position we find the patient. That's a position, is this a position of function for my knee? Yeah? Okay, is it a position of comfort for my patient? Yeah, so typically this is how we're going to splint a knee, all right? So BSI, seems safe. I have my partner. All right, manually stabilize. Here, let's read this just a little bit so they can see better. Manually stabilize, right? I'm going to check PMS, and then I'm going to do what we call the H frame when it comes to splinting your knee, okay? I'm going to have mostly appropriate size splints on either side, okay? Now, guys, even if I securely and snugly put these up against each other, can he still, if he wanted to, or my partner hit a really big pothole, can his knee still extend and flatten out? Yeah, okay, so we are gonna put, can you hand me that really, really small one? We're gonna put a little tabletop underneath these two splits, all right? So even if the big pothole, we hit a big pothole or something happens and jostles his knee, this frame right here is going to keep it from physically flattening out. All right, so partners. Huh?
You get a lot of points.
Okay. All right, so I'm going to secure these splints up to my thigh, up here. Again, guys, you're gonna do a little more snugly than what feels natural. Because if we do it too loose and if things are flopping around, there's no point of putting a splint on, right? Just make sure, hey, I'm not pinching you, and then that's why we go back and we assess PMS to make sure it's not too tight. Okay, and then I need to make sure that this is secure and snug because if my, whoever on scene fire or somebody comes up and hits that, it's moving around, it's not really secured, right? So guys, just start up here with your ACE wrap. Again, there's no 100% right way to do this, but just start doing like a figure 8 kind of motion. That's going around the kind of frame right here. It's securing the frame to the actual splint itself. But notice what I'm not doing. Where am I not putting the ACE wrap? Right on top of that joint, okay? Because how I'm trying to do this figure 8, I can't really evenly distribute the pressure. So this is just to make sure that that's nice and snug and nice and secure. And then I'm gonna do the same thing down here, just snugly secured this part of my patient's legs to the splints. You're good. Okay. PMS, good to go. Do you feel like you can freely do this to your knee? Okay, so we're going to use the H frame when we're securing the knee, because that's more than likely going to be the position of comfort. It's also a position of function. Okay? Any pressing questions on the knee? Oh my ACE wrap over here. All right. So guys, moving down again, tibia, fibula is going to be the next long bone. So you would just do the same kind of like we did with the femur. Okay. We're going to go just a little bit below the ankle, but above the knee on both sides. Okay. BSI, stay safe, partner hold, check PMS exams. Guys, I would secure my splints, my boards up here, and then also secure them around the ankle, okay? And then mummify, wrap it up, do the little ankle hitch that I'm about to show you, and then just make sure starting up here at the knee and then down to the ankle, joint above and below is secured and nice and snug. Go back, reassess PMS, good to go, okay? So for the ankle, do I have, give me those two. We talked about this. So for the ankle, I'm going to show you guys how to make that ankle hitch. Okay. So what needs to be secured? Yes. Okay. So my tarsals, right, or my metatarsals and my tibia fibula. Okay. So in order to do that, I'm going to need a partner. Thanks. All right, guys, so notice that's a pretty good length. I'm going to try to have the length of these splints down here as long or as parallel to the tibia fibula as I can, and then kind of jutting out past the ankle, towards the foot, okay? So again, BSI, seems safe. My partner's holding in manual position. I already checked PMS, right? I'm going to secure the boards down here to my tibia fibula. Okay. Guys, there are a couple different ways that you can do this. Again, there's not one absolute correct way, okay? I was actually recently shown this by one of my previous students, and I like this method. You take your triangle bandage, you tie the knot, you form the little hammock, and you drape that hammock around the toe, or around the top part of the foot, like that. Huh?
Whatever side.
Yeah. And then you take this, you come back around, you loop through, making sure we're not putting that direct pressure on the ankle itself, right? Tie a knot, more is more, right? So, guys, really the main point of an ankle hitch is you're going to cross over these metatarsals here, typically wrap around, and then have the length, ideally this would be longer, but have the extra length coming down here to secure whatever triangle bandage or ace wrap it is down to this part of the remaining split. So I can do that. I can make it a little longer. I can kind of secure it to itself. I need to do the same on the other side. Another ace wrap. Or you could also use this. Remember, it's stretchy, but you can also use it as rope. Just start underneath the foot, crisscross. Make sure we're taking out the slack. And then I'm securing the ankle down here to the rest of the board. Okay. You feel, if you really wanted to, guys, remember a splint is not a what? It's not a cast. It's not concrete going to absolutely restrict motion. Just like a what is not going to absolutely restrict motion. C-collar, right? It's there's a reminder to the patient if for whatever reason they start wiggling, oh, hey, this needs to be nice and snug and secure. He's not going to want to because he's in pain, but if you really wanted to, you probably could forcefully point your toe, right, and move the ankle a little bit. But is it snug enough where you feel that it's nice and tight and we're not going to have a bunch of excess movement if we don't want it to be there? Yeah. Okay.
It's a reminder not to move.
Yeah. No, yeah, it's a reminder. They're not going to want to, but if for whatever reason it starts moving, oh, hey, it's nice and snug, I probably should leave it still. It's not going to happen. They're going to be like, please don't touch me. Please don't hit any potholes. Please don't go over speed bumps. They're not going to move it at all, okay? But it's not going to be 100% motion free when we put a splint on. Because if that were the case, we probably would be restricting what? PMS in some capacity, okay? All right, so reassess, good to go. All right. Guys, what if I do come back and I'm reassessing PMS and I notice that that distal pulse is a lot weaker than it was to start with? Or they are having a tingly sensation. It's too tight. What do I need to do? I need to go back and loosen it up, okay? Usually more than, usually more than not, it's when we are putting the ACE bandage on that we are just stretching it way too tight and we're wrapping it too tightly that we start to see those issues with PMS. Or if you go back and you look at your placement of the triangle bandages, it is directly on top of like a pressure point and it's way too tight. But yeah, if your PMS is affected after you place the splint, just go back and look at it and just loosen it up a little bit and then reassess PMS when you're done with that.
Broken bones will swell. And so it might have been snug when you started, it swells and now it's cutting off circulation. These won't cut off circulation, it's triangle bandages. And just loosen one at a time. Don't just undo the whole thing. Then you're losing stability. Because we know if it's holding it in place, you need to hold it in place a little less tightly. So just loosen up one, check for both. Loosen up another one, check for both. But it's probably around the swelling. It's probably
Everybody okay-ish?
Sometimes crushings, you have to adjust too, because sometimes the bones are all a hot mess in there. If it's more than one fracture site, then you have to kind of readjust to find the right spot. Sometimes you have to get them to work with you. Not pleasant, but you got to restore circulation, not much like you're doing now. Sometimes companies buy those cheap, that's why I threw it down there.
Yeah, I showed
cheap
it
boot
to them.
things, you showed it to them already.
Just the different
They
makes and
suck.
models.
Make sure you have a pillow with them if you use them.
Yeah, you're gonna have to do a lot of void padding
Yeah, there's a lot of those.
in those cardboard ones.
The other thing too is you mentioned the bumps in the road. If you can get your patient actively cooperating with you, like whenever you know that there's a bump coming, because you know how the road is, have them lift their leg off the stretcher, because that bump is not as bad if it's in the air versus on the stretcher.
Or just
I learned that.
manually.
Or manually lift it
Lift
farther
it
than
a
what she
little bit.
says.
Yeah.
But you gotta move with the bumps.
Yeah, I get some head blocks, cut a little groove in it, so you just set it like right
the
Yeah,
there.
so
ankle,
it-
the ankle crate.
Yeah, I mean, those things are cheap, man. So,
Traction splint.
yeah, that's what I do.
I'm sure you're still gonna be the patient.
Might as well. That's why we gotta press it.
Down here.
All right, guys. Again, when can we utilize the traction splint? Isolated closed femur fracture, right? We can't have any pelvic, knee, tib, ankle, or foot involvement.
At least 2 inches from the ends. Maybe the shaft.
Yeah, so if it's like, that's a good point, I didn't talk about that earlier. If the fracture is right here, no go. Okay, it's too close to that knee joint. It's not really gonna do the job that it's supposed to do. It needs to be a nice mid-shaft fracture. So again, guys, these are great if we have a patient who's eligible for them, but that is just a very luck of the draw injury to get that everything like checklist to be eligible for a traction splint. You've had 2?
In 15.
Yeah, 15 years.
Oh, shit.
So,
18 years, too.
yeah. Anything that's specialized is really good at what it does and then it does that. So grade usually uses this kind of stuff because it works on anything. And you don't need 15, you don't have to carry like 2 handfuls of stuff or whatever the problem is. And frankly, what really easy is the fielder. She's about 1/4 inch thin small. Of course.
Thanks. All right, so we'll say his left femur, closed, mid-shaft, isolated femur fracture, okay? So guys, the whole time that we're placing this traction splint, your partner is going to serve as the traction splint. They're going to be manually pulling traction.
So, yeah, pulling. I'm not dragging him around, but trust me, his knee will be moving towards his hip if the femur's broken and I move to the left.
Because remember, guys, we talked about what we'll see typically a lot of times the shortening, sometimes the angulation, because of those muscles just kind of freak out, they tense up, and they're pulling the bone.
Let me get this arm just so we can see. I'm sorry.
Well, it's like bilateral.
We only have one of these.
But you could do 2 if you wanted.
Sure.
If you have bilateral isolated closed femur fractures, yeah.
And they're stable.
All right, so ankle strap. This way, right?
The other cool thing about while they're putting that strap on, the other cool thing about the manual stabilization is it actually releases pain significantly. You have patients that are crying and begging for fentanyl, and then you pull manual and they're like, and then they almost kind of pass out on you because they're in so much pain, and then they're suddenly not. Just because you're pulling those nerves away, because all that jagged bony is going into those nerves and the meat of the thigh. If you stretch it out, it actually a lot less pain. You have to let go. You're gonna get screaming.
Yeah. And guys, they sometimes too, if we don't have traction splints on the truck for whatever reason, you can have somebody manually hold traction the entire ride in. So if fire's on the scene, say, hey, you're coming with me.
Let's sit on the stretcher.
And then they also too, they also too have makeshift traction splints in the trauma bay where they will literally just kind of jerry rig it up, and they will have like 10-pound sandbags dripping, or not dripping, but like hanging off the edge of the stretcher in the trauma bay that will serve as a makeshift traction splint. It looks barbaric, but the patients are like, oh my gosh, please do not like keep doing what you're doing. It feels so much better when you're holding traction. So, all right, guys, you'll measure it on the unaffected side. In real life, I would walk around. I don't want to be really leaning over my patient, but I get up on me, so I don't want to get up as much as I can help it. All right, you'll undo these little knobs down here. I want to make sure that this is going to go right up underneath my patient's butt cheek, okay? And then that this end is going to extend about, swoop. This is why you don't reach over your patient.
Unfortunately, these specialized devices are often incredibly just like
It's a little higher.
What's the big blue part?
Yes. The octagon thing, not the,
Just those.
yeah, those. Yeah, I think there's other notches.
And butt cheek, need it to go out further than that.
So if that person knows I'm holding it in the air, so. So A, she'll have room to get underneath it, and it's just letting gravity work with it.
So again, guys, when that's happening, we want to give a little support under the femur, right? So, because I'm going to have to lift it ever so slightly to get this right up under his butt cheek. Okay. Get to know you a little bit better. All right. We're going to pop the kickstand out. Whoever's holding traction is going to attach the little ankle hitch to the crank. I don't know what the actual windlass. I don't know what the
We
actual.
need a couple more inches actually. Oh, wait, hold on. Right here.
You need more length?
I mean,
Yeah.
this is too low.
It's like rusting together.
They don't care. Let's do this.
Your patient is now pulseless and apneic.
And now has vomitus in his airway. All right. So, gonna start securing these straps. Guys, remember this is gonna be for a mid-shaft fracture. I don't know what that is. No. So, avoid putting the straps directly on the fracture itself, and also avoid putting it directly where?
These straps are just stretchy.
I'll just
Little
say
stretchier
right
than
here
expanded.
above the knee.
If they go across the bar to the bottom to give you support, you're just going over to, so it doesn't bounce up.
Okay. And then, all right, so guys, this is gonna stay on ideally the length of the stretcher. If you have a taller patient, you might have to have somebody down there actually holding up this part of the kickstand, because if it's flopping off the end of the stretcher, it's not gonna be effective. Okay, so that's your traction splint. Everybody good-ish until we start actually playing with it. And you're like, holy crap, how does this go?
What's this? Is this the arm?
Okay. Yes, no, maybe so.
So how do you do the flat top?
What?
Sling and swath. Yep. Pretty much everything can be solved with the upper extremity with a sling and swath.
Yeah, assume your body is immobile. If that makes any sense, because something tied to your body, the joints aren't moving. So
Yeah,
you
guys,
can
your-
just tape it to the body.
Your chest is going to serve as a splint itself.
If you had two broken clavicles, would you sling both of them, or would you just take this whole self together?
You can tell him to give him a big hug and just swap it. Yeah, technically.
And congratulations, you still maintain your life.
Yeah, again, guys, there's not an absolute correct way to do any of these splints as long as the end goal is achieved and we don't negatively affect PMS. I don't care what it looks like. Okay?
Yeah.
Okay. Any questions on Zoom?
None that I can think of.
Hey, actually, if we come in on a morning or something like that, if we're not coming in for class, where would some of these items be that we could practice?
Yeah, so guys, I'm gonna get these put back into the lab room. They're gonna be in the Home Depot, the orange Home Depot hallway. It's the second room on the left, the one that says trauma skills.
Thank you.
Okay.
Didn't you mention that you wanted us to bring in our over feedback?
You misheard that.
I was looking on the drive all the way from